Good day, everyone. My name is Mohamed Zaafarani, and I'm a diamond member of Style Italiano Endodontics. It's a real pleasure to be with you today to share insights on one of the most important aspects of our practice, which is shaping. The title of my lecture is Whispers in the Canal, a minimally invasive shaping approach using the R1 Mini. Together, we'll explore how precision and preservation can go hand in hand to achieve safer, more predictable outcomes for our patients. So, root canal treatment has two main paths, the mechanical and the biological. Mechanically, children taught us to shape a smooth, tapering funnel, respect the natural canal anatomy, and keep the apex as small as possible. Biologically, the mission is clear: stay within the canal, remove every trace of infection, and create a space for healing. So these goals laid the foundation of endodontics as it still guide us today. On paper, root canal preparation has two simple goals: remove infection and shape the canal for obturation. But under the surface, there are complexities. The canal twists and curves in unpredictable ways. The microbial load fights back with biofilms. And hidden microanatomical spaces like isthmuses, fins, apical deltas escape the reach of our instruments. So what looks simple is in fact a battle against biology and anatomy. So no matter how perfectly we achieve every objective of endodontic treatment, cleaning, shaping, and obturation, the final chapter of healing is not written by our instruments. It's written by the body's own defense, immunity. Immunity remains the decisive force, the ultimate player in the healing of periapical lesions. So let me show you this case. Here's a patient who came to me a long time ago with periapical lesion related to distal root. I had working lens, and during shaping, I separate a file beyond the apex. So that time I don't have any tools or don't have enough experience to deal with that broken file, so I decided to leave it and do obturation. And I called the patient after 1 week for microapical surgery because for me, case like this was separated file beyond the apex and periapical lesion, so this file become a permanent source of infection. Luckily, the patient didn't attend, and she came after 3 years. And here was the follow-up after 3 years. The file become like a part of bone. Complete healing happened, and the tooth completely asymptomatic. So immunity play an important role in healing of periapical lesion no matter what we did inside the canal. For years, endodontics had carried out a strong question: does cleaning and shaping damage the tooth integrity? In 2009, �𝗏𝗃 and his team shook the field, reporting that unprepared canals were defect-free, while those treated with Gates Gladden drills and rotary files showed a wave of microcracks. But more recent studies raised doubts. They argued that sectioning, dehydration, even extraction itself might create false crack, not the treatment. So the question remained unanswered. Are root canal procedure truly create micro cracks and weaken the tooth? Here we are talking about the ongoing debate about whether root canal instrumentation cause dentinal microcrack and make teeth weaker or not. Two studies looked at this question but gave opposite results. So the first one by El Nasser and Abdel Kader in 2014 found microcracks after root canal treatment and tried to link them with fracture resistance. But Cavalcante and his team in 2020 studied teeth that already had macro cracks and found no real connection between the cracks and the tooth fracture. A more recent study in 2021 showed that cracks don't really spread much in untreated teeth and only a small amount after years of chewing cycle. So finally, the shape and design of instruments might play a role on how cracks behave over time, but we still don't have a clear-cut threshold linking dentine loss to root fracture. And now we'll explore why files can break, what are the factors that increase the risk. By understanding the mechanics behind file separation, we can shape more safely, protect our instruments, and deliver better outcome to our patient. So there are two main reasons why rotary files separate during use. The first is cyclic fatigue, which happens when file rotate freely around the curved canal. The file keeps bending back and forth until it eventually breaks. Most of the time, this occurs at the point of maximum flexure, the sharpest curve of the canal. The second is the torsional stress, and this one occurs when the file tip or part of the file gets locked inside the canal while the rest of the shaft keeps rotating. This twisting force can exceed material's limit and cause file to separate. So both cyclic fatigue and torsional stresses are key factors we need to understand in order to reduce the file breakage. So our files can break either by one of these two reasons or both in the same case. Sometimes we're dealing with a curved canal and tight one. So our files are exposed to both kind of stresses, cyclic and torsional stresses. Let's explore more what we mean by cyclic fatigue. When a file rotates around the curve, from inside the curve, our file is exposed to compressing forces or compression. However, from outside the curve, or we call it the outer wall, we have a stretching forces. And as the file continues to rotate around the curve, so the inner side become out on the outer wall and the outer become the inner wall. So our file keeps exposed to cycles of compression and tension till it fatigued and fracture happen. Like we can see here, tension and compression, and mostly this happen at the sharpest part of the curve inside the canal. The second reason is the torsional stresses, and as we described, the tip of the file or part of the file got locked inside the canal while the shaft continue rotates. So it might keep rotating until it exceeds the limits of that the file can afford, then separation would happen. So here if we look to this kind of radiograph, the radiographs on the left shows a kind of fracture that usually happen because of cyclic fatigue. And we can understand this clearly because the file gets separated at the sharpest point on the curve. For sure, our file also might be exposed to torsional stresses, but cyclic stresses are already there. However, on the right side, these files never exposed to this kind of fatigue, which is the cyclic stresses. And here it got separated because of torsional stresses only. For sure, almost are engaged inside the canal. And we have some factors that contribute to separation of endodontic files, starting by the operator proficiency. So training and adequate skills are imperative for all dental procedures, particularly in endodontics. Experience with file separation differs not only between practitioners, but also at different times for the same practitioner. Files should be examined before and after use to ensure blades are regularly aligned. Files should be used according to manufacturer instruction to avoid excessive forces, especially in beginner's hand. And instruments should not be used in dry canals. That's why irrigation is important. So actually mastering instrumentation and improving operator competence through learning and experience are crucial to avoid rotary file separation. the complex system of root canal system that could include the canal curvature factor. And here we need to understand the difference between the angle and the radius of the curvature. So as the curvature increases, the cyclic fatigue of the instruments is greater and its life expectancy is lower. Even if two canals have the same angle, they may have different radius, indicating some curves are sharper than the others. So here, the radius of the curve is more relative to incidence of file separation more than the angle of the curve itself. When it comes to metal alloy and file design, we know that stainless steel files are preferable to carbon steel instruments before they are higher quality. However, 𝗫𝗏 files are 3 times stronger, more flexible, and have superior resistance to torsional fracture compared to stainless steel files. The cross-section of the file have great impact also in binding into the canal and hence affect the file separation because active instruments have cutting blades and cut more effectively, while passive instruments have radial lines between cutting edge and flute, performing a scraping action. So it is more scraping action rather than actual cutting. When it comes to the diameter of the file, we know that larger file diameter increase force need to unwind or fracture, so it is more resistant to fracture. Some studies shows that there is no negative effect of all meaning of sterilization on damaging instruments or our files. However, as I reported, only minor or even significant effect, but they concluded these changes aren't clinically important. A few studies even found that sterilization can increase the resistance of files, making them less likely to fail. On the other hand, in the UK, the chief dental officer has recommended using endodontic files only once. This is because of concern that sterilization may not completely remove certain agents like prions. So while the evidence is mixed, the clinical recommendation vary depending on level of caution applied. Regarding torque and rotation speed, for sure they affect file performance. When file diameter increase, more torque is needed, but this also raises the risk of unwinding or fracture. High torque makes instruments more aggressive, which increases the chance of locking, deformation, or separation. Smaller files or files in very curvy canals tend to fail at lower torque. However, when it comes to rotation speed, higher speed instruments separate more often and their lifespan decreases. However, some studies found no clear link between speed and fracture, so the evidence is quite mixed. Instrumentation procedure also is one of the factors contribute to file separation, as every step of instrumentation carries both promise and risk. So pre-flaring opens the way, easing torsional stresses and revealing the hidden anatomy of the canal. It creates a safe path, a foundation for everything that follows. The sequence of instrumentation also play an important role through it demands more steps, yes, but it protect each file with less stress, make it last longer. And when different systems also combined, we call it hybridization, the clinician gain more control. That's what I love to do always, is to hybridize or mix instruments. But irrigation, while vital, it has also its own danger because corrosion creeps in. Some studies shows that with the irrigation with sodium hypochlorite or long time exposure to sodium hypochlorite will cause the file to corrode faster or easily. That can weaken instruments and make it more prone to separation. Dentinal debris also is one of the factors that contribute to separation of endodontic files. When we shape canals, dentine chips are created. These ships can build up on the file itself, increasing friction and concentrating stresses over time. This makes our files or our nickel titanium rotary instruments more likely to deform or fracture. That's why effective irrigation and debris removal are key, not only for cleaning but also for protecting our instruments. Selection of a good endomotor is also a factor. Yes, it might sound strange for some, but believe me, safety features in endodontic motors such as torque control, auto reverse, the adaptive motion, the OTR, ATR, and speed regulation play a very, very critical role in reducing the risk of file separation. So these features help to prevent excessive torsional stresses and cyclic fatigue on rotary instruments by adjusting motion or adapting motion, sometimes reversing rotation when resistance is detected. So, endomotor not only extend instrument lifespan but also enhance clinical safety, efficiency, and treatment predictability. And here we come to the end of the first part regarding why our files separate, the reason behind or factors behind file separation. We can come with some recommendation to prevent file separation. Start with preparation and awareness. Make sure you are well trained before working with newly designed instruments. Having a solid understanding of root canal anatomy and always secure a glide path before shaping. Check every file carefully. Sometimes manufacturing flaws, and it can happen. During treatment, don't forget also to recheck your files even if they are only being used once. Rely on magnification, since small defects often unseen by the naked eye, and above all, respect the manufacturer's guideline for each file system unless you are expert enough so you can modify. By following these principles, especially for beginners, you reduce risk and improve safety in every case. Now let's talk about the kinematics, and I believe that I discussed this part before, but because of its importance, I will try to repeat in a different way so can make it more understandable. So in endodontics, different motions of instruments play a critical role in shaping and cleaning of the canals. First, we have continuous rotation, where the instruments make a full 360-degree turn in one direction. Usually it's clockwise. Next motion is alternating reciprocation, where the instrument moves in equal clockwise and counterclockwise angles, usually less than 90 degrees, without making a full rotation. And here, sometimes we need a little bit of force to make our file goes towards the apex. Then comes the rotating reciprocation, where one angle is larger than the other, either clockwise greater than counterclockwise or vice versa. Finally, combined motions, where two or more of these movements are automatically generated by the motor. Each motion has its own advantage and application, so understanding them is key to safe and efficient endodontic practice. Let me explain more. Here is a continuous rotation where the instruments make a full 360-degree turn in one direction, usually clockwise. Alternate reciprocation, the instrument moves in equal clockwise and counterclockwise angles, less than 90 degrees. Rotating reciprocation, where one angle is larger than the other, here it's counterclockwise, and the release is clockwise. And this one is a combined motion, we call it ATR, where we have combination between continuous rotation and the rotating reciprocation for more safer procedure. That's why I want to tell you, if we look at these two motions, both are continuous rotation, but one in clockwise direction, like this one, And the other one is continuous rotation also, but in counterclockwise direction. So if you know direction of cutting blades, you can use rotary file in reciprocating motion. And you can use also reciprocating files in rotary motion. That's why we always love to say, respect the direction of the blade. Once you understand and you know the direction of the blade, you can play with your file as you want. Rotary, reciprocation, ATR, whatever you want, you can customize. In this study published in the Dental Research Journal, they were comparing two different kinematics in endodontic retreatment for rotation and reciprocation. And the goal in this study was to evaluate which movement is more effective in regaining apical patency, which is critical factor for sure in successful retreatment cases. The results were interesting. In straight canals, both rotation and reciprocation achieved apical patency equally. With no significant difference for sure between them because case is already easy. But in moderate curved canals, reciprocation showed a higher success rate because with reciprocation we don't have the complete engagement of the file of the canal. However, the file has a release angle which decreases stresses on the file while rotating. Although it is not statistically significant, but still it demonstrates a safer trend compared to for rotation. And in this systematic review and meta-analysis comparing rotary and reciprocating endodontic files in terms of cyclic fatigue resistance, across multiple studies, the evidence is clear. Reciprocating files consistently resist cyclic fatigue better than rotary files. In both straight and curved canals, reciprocation showed higher resistance and longer time to fracture, making it safer choice to reduce instrument separation during endodontic instrumentation. Another study, and in this one, investigation to the effect of continuous rotation versus optimal torque reverse, or we call it OTR motion, on the cyclic fatigue strength of nickel titanium. The findings were clear. When the files were used in OTR motion, their time to fracture significantly increased compared to continuous rotation. So OTR also reduced micro cracks in the metal, helping preserve the integrity of the instrument. So, to make it short, optimal torque reverse improve file durability and lower the risk of file separation, making it a greater alternative to full continuous rotation. And now I'm sharing with you my preferable setting for playing with the R1 mini file from Fanta Dental. A very nice file introduced as a reciprocating system, which I'll show you that I love also to use it in continuous rotation, but for sure in counterclockwise direction because I'm respecting the plate. So with the R1 mini, my go-to for straightforward cases is continuous counterclockwise rotation at 500 degrees RPM and 2 Newton centimeter torque. Smooth and efficient and precise and also straightforward. But when challenge rises, moderate to difficult cases, I switch my gear to OTR motion. On the iRoot Pro, with reciprocation angles of 150 degrees counterclockwise and 30 degrees clockwise. So this way, I combine the speed and cutting efficiency of rotation while with the built-in safety and stress in the iRoot Pro, stress relief of reciprocation, that perfect balance of power and the protection also in every aspect of shaping. So after we explore together the different kinematics of endodontic instruments and how they are important, it's important also to say that shaping should always be carried out with respect to the concept of minimally invasive endodontics. So while understanding motion is essential, the ultimate goal is to preserve as much tooth structure as possible, ensuring both safety and long-term strength to the tooth. And when we talk about minimally invasive shaping, the goal is to create a smooth, conservative connection from the coronal to the apical third, without excessive flaring, to respect and maintain as much as possible from the pericervical dentine. So here you can see that with the R1 mini system, the opener or the orifice opener at D13, the file maintain a narrow diameter of 1.1 millimeter, while with the shaper at D16 it maintains the same narrow diameter of 1.1 millimeter. So the maximum fluid diameter of the R1 mini is 1.1 millimeter. That ensures that shaping is effective yet still respectful of dentine preservation. So this is a balance between efficiency, conservation, that what makes minimally invasive shaping possible. Now let's move to some clinical cases, but before going into clinical cases, let me show you this demo using the R1 mini on this difficult model. Let's apply what we discussed on a model before following into clinical cases. In this multilateral curved tooth premolar, we need to start by pre-flaring, maybe a little bit of brushing to enhance the accessibility to the apical third of the canal. That should be followed by good irrigation or frequent irrigation. Then we need to create or establish the glide path, gently establish glide path in watch winding motion. Don't be in a hurry. We need to take our time to safely negotiate the canal till the apical foramen. For sure, it is not a must to have it in one shot like I'm using now. Zone technique, good irrigation. Then I can follow again with a new file or the same file if it's still in good shape to negotiate the canal till the apical third. Watch winding motion. In some cases, I would love to do some filing motion to make it more smooth. But in a curved canal like this, if we do filing motion, sometimes we may straighten the curve. Now I'm following with a glide path file 1704 from the R1 mini in adaptive motion or in OTR using iRoot Pro. And here we can understand while the file feel or have more resistance or more torque, it switched to reciprocating motion. Here it's clear. Now shift to reciprocating motion, so it is more safe in managing this difficult anatomy. Then we need to re-irrigate. This way we re-establish the mechanical glide path. Here I'm shaping the coronal portion of the file to resistance using the 2506. Then confirming patency. A little bit of filing, then good irrigation. That should be followed by full working length shaping using 2506, and again it's in OTR mode. So my file is adjusted in continuous rotation in counterclockwise direction, and the OTR when torque increase than 1.5 Newton per centimeter, it will shift to reciprocating motion. This is what we call combined motion. I would prefer it in difficult cases like this. And here is a master cone fit. And we need to make sure that our preparation is conservative, as you can see on the left side in the radiograph, conservative, and also is respecting the root anatomy. For sure, some straightening to the first curve is there, but this is a must to reach safely to the apical curve and shape it without any transportation or uneven reduction in the coronal portion of the file. Going into clinical cases, here is a case of retreatment, and I would like to say that reciprocating files are very efficient in 𝗪𝗵𝗶𝗀𝗃 removal, especially using it in OTR, so it is more safe when the file got engaged inside the soft 𝗪𝗵𝗃. It will shift to OTR when needed for a safer preparation. So here is a case of retreatment with periapical lesion related to the distal root. So it's a previously treated tooth with chronic apical periodontitis. starting by ultrasonic to remove the old restoration from the floor, exposing the old 𝗪𝗶𝗀𝗃𝗀, and here you can see that we have fluid coming from the distal canals, which is an abscess. So this case is a chronic apical abscess. Continue with ultrasonics in dry field so we can clearly see where our tip's cutting. Then we need to open coolant to flush away all the fillings and debris to make it more clear to continue our cleaning and removal of all the 𝗪𝗃𝗀𝗃. Then we can continue again with ultrasonics, soften some coronal 𝗪𝗃𝗃𝗃 so it would make it more easy for all files to engage into the old 𝗪𝗃𝗃. Again, working in dry field. Once we were not able to see or to have too much of debris, open coolant, flush away all debris. Now it's more clear to go for 𝗪𝗃𝗃𝗃 removal, and here I started by the 2506 in counterclockwise direction rotation on OTR, and here we can feel how efficient is the cutting, how efficient is the removal of 𝗪𝗃𝗃𝗃. So reciprocating system, now I'm using in rotary motion, but in counterclockwise direction. Again for the mesolingual canal, and here you can see that file shift into reciprocation thanks to the OTR mode on 𝗪𝗵𝗽𝗶𝘀. Again, very efficient in removal of all 𝗪𝗃𝗃𝗃. Sometimes it's quite slower, but safety comes first. A little bit of brushing. What I'm doing now is limited to the coronal and the middle portion of the canal. I'm not taking my file to the full length. Still, canal is not patent, and I don't want to put much force on my file. And here, I missed this to buccal canal. Again, shaping and pre-flaring on OTR, on 𝗪𝗵𝗃𝗀. 𝗪𝗃𝗃𝗃 removal from second distal canal using the R1 Mini 2506 with maximum fluid diameter of 1.1 millimeter, but on OTR motion. It's like a saw. You can clearly see how 𝗪𝗃𝗃𝗃 is coming in ships. Here's pus coming out from the distolingual canal. Good irrigation. Better to avoid the use of sodium hypochlorite if you have too much of pus coming out, so to avoid liquefaction of the pus. Now I'm following with a mechanical glide path using 1704 in counterclockwise direction, continuous rotation. It followed to the full length of 4 canals. Now I'm doing complete shaping using 2506 to full length. It's a regressive taper file. We need to make sure that our files are conservative in shaping. It's not about removing lutein. The idea is to preserve as much as possible from tooth structure. Sometimes in cases of retreatment like this, we need to extend a little bit our preparation, like in distal canal. Here I'm activating my irrigant using the Actor Eye Pro cordless ultrasonic activation device from Fanta Dental. Very, very efficient. I can say that it's the best among its class from other tools from the companies which are producing cordless ultrasonic. I love this one. Continuous activation should be done 1 minute in each canal after complete shaping with alternate use of 𝗪𝗵𝗶𝗀𝗃𝗃 and the EDTA for removal of a smear layer, providing better contact of 𝗪𝗵𝗶𝗀𝗃𝗃 to dentine. And here is the case after complete shaping and cleaning by ceramic sealer. Now, 𝗕𝗵𝗶𝗀𝗃𝗃𝗃 canal. And distal canals, which are confluent canals. And here's a case after obturation using modified heat technique using bioceramic sealer and 𝗬𝗪𝗏𝗃𝗀. And here's a case after obturation, beautiful shapes. You can see here that we don't have too much reduction in coronal portion. Widen was important for better delivery of our irrigation to the apex. And here is the case of distal canal, multidonal curvature. We maintained also the curvature in the distal root, so that was a safer preparation using the R1 Mini on iRoot Pro, using counterclockwise continuous rotation and OTR motion. Another case where we have large lesion, and clearly we can see here capping material, which commonly is a pulpotic because we can see a calcified or extremely narrow canals in the mesial root, while in distal is not. So this is known as the effect of bulb devitalizers or phenolic component to cause this kind of response of the bulb by coronal narrowing of the canal. But this is not the only problem in the case. The problem also that the patient was with a limited mouth opening. So clinically, starting also by ultrasonics to remove all the capping material, thanks to magnification and ultrasonics. Access refinement, coolant to flush away debris. Clearly we can see the orifices or the entrance of the canal thanks to the dentine map and dark colors on the floor that guide us to the site of the canal. And here I am going to negotiate the coronal part of the canal using 1704 from the R1 Mini. So especially for very narrow canals, don't start by orifice opener or large tapers file. Mechanical glide path file are recommended for negotiation of the coronal portion. Here in the mesolingual canal, you can clearly see how tight is the patient mouth or how narrow is the patient mouth. Make shaping quite challenging, especially for a second molar. Irrigation. So now the coronal portion of the canal is patent. I'm using 1704 R1 Mini in counterclockwise continuous rotation because I'm respecting the blade. Now I would pre-flare the coronal portion using the 2506 or 2506 from the coronal portion. Sorry, this is an orifice opener. Yeah, pre-flaring after glide path. Yeah, we can use the orifice opener now. It's safe to use it. For sure, the opener we are using in continuous rotation, but in clockwise direction. Here for the other mesial canal. Difficult accessibility. Accessibility is too difficult. A little bit of brushing on the outer wall, and I know that the file has maximum flue diameter 1.1 millimeter at D13, and I'm not taking the file to full working length for sure. So still also our preparation is more conservative. Here for the distal canal, with a little bit of brushing. And here's the case after coronal flaring. Now I'm starting by the mechanical glide path file 1704 in counterclockwise direction on OTR, so it would shift to reciprocation when there is high torque or high stresses on the file. Sodium hypochlorite irrigation. Thanks to the pre-bendability of the 𝗪𝗵𝗶𝗀𝗆, enhancing the accessibility in limited mouth opening patient. Again in OTR. So now cutting in counterclockwise, shifting to reciprocation where it is difficult to negotiate or to shape. Continuing the other canal. Now shaping we are doing to full length. This way our file can resist torsional and cyclic stresses, making it more resistant to separation or long time needed to get this file separated inside the canal. Here irrigation, for sure we need to activate our irrigant to enhance contact between sodium hypochlorite and contaminated dentine for easier penetration also of hypochlorite into dentinal tubules. And here's the case after complete shaping. And after obturation in modified heat technique using 𝗪𝗵𝗽𝗀𝗃 and bioceramic sealer. And here's the radiographic workflow. Distal canal, you can see it is wide as the apex, so the tug back we had here was a false tug back, but it's okay with bioceramic sealer as long as this part would be filled by bioceramic sealer and 𝗪𝗵𝗽𝗀𝗃. And you can appreciate here the conservative preparation for a very narrow canal, thanks to the 1.1 maximum fluid diameter of the R1 Mini, thanks to the iRoot Pro and the adaptive motion, the OTR, that shift the motion from continuous rotation in counterclockwise with the R1 Mini into reciprocating motion 150 degrees counterclockwise, 30 degrees clockwise for releasing stresses. At the end, I would like to say that lately I started to shift to the R1 Mini as my main system because what I see, the conservation of preparation and how this file can resist files separation because of the higher resistance of cyclic fatigue and torsional stresses, because of the cross section, because of the alloy, because of the regressive taper, and for sure the heat treatment, because we have also hybrid heat treatment in this file. The 1704 is made from more stiff alloy than the 2506 because at the end of preparation we need the flexible files. So that was my today's webinar. I hope you enjoyed the webinar. So it's considered like number 7 or number 8 webinar about shaping with different ideas, different cases. I hope you are enjoying this series and see you soon in another webinar. Stay safe and bye-bye.